Today is a very exciting day, to be able to come and share with you some of the work that's been done by David. He's here to talk about something which really excites us. And I'm going to leave him to do the main bulk of the talking, but I wanted to share with you why is it that we are so excited, okay? Every day we see cancer patients, and every day we have to make very hard decisions in terms of how we look after these patients. There are many challenges and indeed there have been many advances to help us to overcome some of the difficult issues in caring for cancer patients. It's no secret, 1 in 3 Singaporeans will die because of cancer. So we are not doing a good job, okay? Let's not kid ourselves. If we were doing a good job, we won't be seeing cancer as the leading cause of death. Way back when I first started doing oncology, I still remember the slide used to say, 1/4 of the people die from cancer, 1/4 of the people die from heart disease. But the cardiologists have done a good job. Somehow they have been able to help patients to such an extent whereby it doesn't become a cause of death. It may indeed continue to cause a great deal of morbidity, but indeed not mortality. But for us, we aren't doing a good job because the incidence of cancer is continuing to rise, and the fact is we are not curing these patients, and thereby many patients are still dying as a result of cancer. So 1 in 3 patients who die will die because of cancer. Whenever we see a patient, there are many things that goes through our mind. Okay, the things that we have to sort out before we need to sort out for the patient. The first is making the diagnosis of cancer. The second is determining the extent of cancer spread. The third is planning an appropriate strategy for that particular patient. Number 4 is selecting the best possible drug program. And then, of course, to provide the psychosocial support that's so much needed for every cancer patient. Making the diagnosis. I still remember in the good old days when I was a medical student, when we talk about making a diagnosis, it meant just looking under the microscope and telling ourselves, is this a cancer cell? Is it not a cancer cell? Where is the cancer cell originating from? And that's it. If you can get that, you're going to get a distinction in pathology. But now, we need to know so much more. And the good news is, the pathologists, they are making a major difference in helping us. Not just to make the simple diagnosis, this patient has colorectal cancer. We want to know so much more. In lymphoma, we want to know whether it's a B-cell lymphoma, a T-cell lymphoma. We want to know whether it's CD20 positive. We want to know whether it's got double hit. We want to know the genetics of the cancer. And this is so important because the pharmaceutical industry has been helping us by developing so many new drugs. And these drugs are not just blunderbuss drugs which hit at everything under the sun, but they're very specific. All right? For example, in lung cancer, a very, very small percentage, I believe it's 5% of lung cancer. Kay Siong, am I right? For ALK positive? 2%, sorry, I'm wrong. 2% of lung cancer patients are ALK positive. Now, that means that if you use this particular drug called crizotinib and you just give it to every lung cancer patient, you're wasting money in 98% of the time. But if you confirm that someone is ALK positive and you give them crizotinib, there's a very, very high chance that this patient is going to respond to treatment. So one of the major things for us to remember is that we are now understanding cancer at the molecular level, and that is helping us tremendously in the way we treat the cancers. What does it mean? It just means that we need tissue. All right, either by a needle or a core or sometimes an open biopsy. We need to get those cells, examine them under the microscope, do the appropriate staining, do the necessary tests in order to reach the appropriate diagnosis. Making the diagnosis is step number 1. The second is obviously knowing the extent of cancer spread. And that's where radiology, we have seen the many, many advances. From the old days where we just used plain X-rays, ultrasound, CT scan, MRI, now we talk about all the different nuclear scans, the PET scan, the PET MRI, and the PET CT. PCC is indeed very fortunate that we are working together with the Parkway Hospitals, and we have a PET MRI that is sited in Mount E Novena. And this has helped us to be able to to look at the structures more, define the structures more accurately, and to know where the cancer is. All right, this is of course a CT scan showing that the liver is completely studded. This is a PET CT scan. The PET CT scan, I've said this many times, and I'm sure some of you have seen these slides before. You can see this is a CT scan that looks completely normal. Completely normal. You can't tell where the disease is. But the moment you inject FDG, you can see that in actual fact, this patient has a pancreatic cancer. Now, what is FDG? What is a PET CT scan? We know that cancer cells have got this avidity, this fondness of sugar. All right? By tagging on a radioactive substance to the sugar, we inject it in a fasted patient, and the sugar goes to where it is metabolically active, helping us to identify where is the site of involvement. And this is extremely important because it can tell us whether the disease is indeed localized or not. Another example, this is a CT scan of the pelvis. You can see this is the tailbone, this is the pelvic bone, and these are the intestines inside. And when the PET scan is done, you see, lo and behold, this little dot that looked quite normal, quite innocuous, is in actual fact where the cancer is. This is extremely useful to us. This means that we are now able to stage patients better. The other day, there was a question in the media asked, why is it that we seem to be picking up more stage 4 cancers? Is it because patients are presenting later? Well, I don't think so. I think the real reason is because the standards of medical practice are higher. Gone are the days when you can decide to operate on a patient on the basis of a chest x-ray. All right? With more investigations, you're often able to detect disease which otherwise would have been missed. So now we are actually staging patients more accurately. And because of that, it appears as though patients are presenting at a more advanced stage. The PET scan is extremely useful in helping us to tell us whether the disease is responding to treatment. As you can see, this is a patient with lung cancer and how well they respond. So the PET scan is useful in telling us whether that shadow is still metabolically active or not active. In other words, is the disease still alive or not? As far as treatment is concerned, the three main arms of treatment are surgery, radiotherapy, and the use of drugs. Surgery remains the cornerstone in the management of cancer. The surgeons were very afraid for a very long time. They said, look, if you get new drugs, all the time, does it mean that there's no more role for surgery? No, I think far from it. Indeed, surgery plays a very important role whenever the disease is localized. Radiotherapy is also very important. Whenever there is disease that's radiosensitive, for example, in nasopharyngeal cancer, I often tell my patients this. If you had to choose between chemotherapy and radiotherapy for localized NPC, you could only afford to do one of the two. Go for the radiotherapy, because that gives you a chance of a cure. Chemotherapy is, of course, very useful in treating systemic disease. This is an example of a patient with a carcinoma, all right, involving the cheekbone. The surgeons these days are really very good. They can literally tear your face apart, and put it back together. All right, this patient I looked after way back, I think definitely more than 10 years ago, It remains alive and well. At first, she was very reluctant to have any form of a plastic surgery, and she lived with this flap, that was a little bit too big for a very long time, but only after about 5 or 7 years after the initial surgery, she said, well, maybe I should do something about it, and then went for some form of a surgery in order to get better cosmesis. So the surgeon plays a very important role. Even when diseases may appear to be very locally advanced, they now have the capability of looking after and caring for these patients because the whole field of medicine has improved. The care before, during, and after surgery makes a major difference in terms of the outcome. But more important than that, the surgeons now begin to realize and understand that every cancer has a certain biology. In the past, we thought that in breast cancer, the bigger the operation, the better. If you could take off the breast, is good. If you can take off the breast with the muscle, you are even better. And they thought that more and more, the more radical the surgery is, the better the outcome. When now they realize, it's all rubbish. You don't need to do radical surgery. In actual fact, if the tumor is small enough, you can just do a lumpectomy with clear margins, offer radiotherapy, and the results are as good as having a mastectomy. And you can see These are patients who sometimes choose to have a mastectomy, but because the plastic surgeons do such a wonderful job in reconstruction. Okay? Radiotherapy has also improved. Technology has made a major difference. The tomotherapy machine has made a big difference for patients who need radiotherapy. You can see these are NPC patients with fairly disease with a nodal involvement, how well they respond to chemotherapy and radiation. All right? And you can see it's especially important in the nasopharynx because you're shooting an area whereby the neighboring structures are all very vital. The eyes are in between, the eyes are on either side, the brainstem is behind. So your radiotherapy must be very well planned. And that's one of the big advantages of the tomotherapy. It helps us to achieve very good, concentration of radiation beams at the target and sparing the neighboring structures. The sad truth about cancer is, as I said, cancer patients often present with very advanced stage disease. And there are many reasons. Number one is that cancer in its early stages have got no symptoms. You can be having a lung cancer or a liver cancer growing in you for months, maybe even years, without you even knowing that it is there. By the time you know it's there, it's already very late. And the second is that symptoms of cancer are very non-specific, so making early diagnosis very difficult. Maybe the gastric pain that you felt today was just gastritis, but maybe it's a cancer of the stomach. You noticed this morning when you wiped yourself after bowel movement, there was some blood. Maybe it's just piles, but maybe it's colon cancer. Because of the non-specific nature of the symptoms, it's very often for people to say, maybe it's nothing, but actually it is something. And of course, some people are so fearful. They deny, they say they probably know there is cancer, but they bluff themselves and say, no, this is not cancer. And some are very afraid to make the diagnosis of cancer because they are very afraid that cancer is not curable, and of course they are worried about the side effects of treatment. Chemotherapy has made a major difference in the way we care for patients. In some of the cancers, we have really, through chemotherapy, been able to beat cancer, cure cancer. Of course, the best illustration is lymphoma. Lymphoma is a disease, a cancer of the lymph node, is highly chemosensitive. Now with the agents that we have, we can cure the large majority of patients who present with lymphoma. But the same is not true for many other cancers once they are advanced. This is a lady who came to see me. She's a doctor, believe it or not. And the first doctor she ever saw, other than herself in the mirror, was me. All right, because she didn't think that cancer was something that was treatable. In actual fact, she had a HER2 positive breast cancer, and with treatment, you can see the marvelous results. She was able to continue working. So, these are the success stories. These are the stories that encourage us. All right, this is an advanced tongue cancer which had recurred after surgery, and you can see how well we've done by the use of drugs. This is a patient with lung cancer, and you can see how well they respond just by taking tablet Iressa. So we've got many reasons to be very proud of ourselves for what we have achieved. But the sad truth is that in many of these patients with stage 4 disease, while you can be very happy and show your slides and say how well we have done, how much we have helped these patients, many of these patients recur. And then when they recur, we often have to come up with second line of treatment. And if you're good enough and they respond well, you have to still worry about the third line of treatment, and the fourth line, and the fifth line, and the sixth line of treatment. And every time you go down one line, your odds of success gradually diminishes. And whether you succeed or you fail, the patient has to pay you. The patient has to pay in terms of side effects of treatment. And that's why, much as we are pleased with the results that we are achieving, look at this man, 75-year-old, the liver is studded full of cancer. We did such a marvelous job. I patted myself on the back. But he responded to one line of treatment. When we hit him the second line, he didn't respond. The third line, he didn't respond, and he died. All right. But before he died, he went on to line 2 and line 3 of treatment. Now, sorry. This is a big lump here. So, in many cancers, ovarian cancer, we are only curing 25% of the ovarian cancers that we are seeing. Meaning that before you do anything, you can already tell the patient, look, you've got a 75% chance you're going to fail and you're going to need more treatment. All right, this is a lady whom I just looked after. You can see she has got ovarian cancer, very extensive disease in the liver, in the peritoneum, in the bones. And you know, she came to see me in December and I just did the evaluation in January and I could tell her the good news. I said, look, ma'am, I've done you a favor. See how well you've responded. And then she asked, of course, can I be cured? And of course, I had to tell her, no, while you think you've done well, you can't be cured. So she asked, what are you going to do when the disease comes back? And that's a real dilemma. Because while the first line of treatment has a high probability of success, your second line of treatment, third line of treatment, your chances diminish. And that's why we are so keen on collaborating with Champions Oncology. We hope that they will be able to help us to do preclinical testing, meaning testing in an animal model, so that our patients can have a better chance of success, especially when it comes to the second line and the third line of treatment. So when we saw the data that they presented, we were very excited and we said, look, why don't you come to Asia? Why don't you use Parkway Cancer Center as your launching pad, for us to collaborate and bring this to this part of the region? Because we are committed, PCC is committed to provide the best possible care for our cancer patients. And our care is not just medical. Our care includes, many of you here from Can Hope, to provide the psychosocial support that's so much needed for our cancer patients. These are our cancer support groups, the Look Good, Feel Good class, our Can Friends, and so on. So we are committed to work together with any partner, wherever it may be, in order to be able to deliver the hope for the future for our patients. Thank you, ladies and gentlemen.